untreatable. Delays in recognition, referral, diagnosis, treatment continue to place babies at risk of very avoidable complications. So today's discussion, we are going to focus on how we can identify those gaps, work together as pediatricians, nurses, midwives, public health professionals, traditional birth attendants, and even as parents to improve outcomes for these newborns in Ghana. We are delighted to have an excellent panel of experts and the parents who will also share their real life experiences. So to start off the meeting, I would like to welcome Dr. Med Ernestina Shandorf, who happens to be our chairperson of the PSG branch, Greater Accra region, to give us some opening remarks. Dr. Shandorf, over to you, please.
Thank you very much, Dr. Sharon Ogbebiche. So a very good evening to all of us. And I'm very excited about today's webinar, and I hope you are too, because May has been our Newborn Jaundice Awareness Month, and we've done a lot of advocacy. Today, we are going to be more curious, more open, more transparent, and discuss exactly the things we can do to make this a thing of the past. It's quite saddening that in 2026, we still have babies who die because of something as preventable or something as treatable as neonatal jaundice. And it's my desire that all of us would be of the same mindset so that we can find and address these challenges so that no child has to suffer the consequence of complicated neonatal jaundice or cerebral palsy, neurodevelopmental delays, or even death. So as we have this webinar today, I implore all of us to participate. Let's be part of the discussion. Let's be open. Let's be curious. Let's be transparent. Let's make decisions that would help our children. We would have a session where we learn about other causes of neonatal jaundice, and then we have a discussion how to make the situation better. So without much ado, let me say a very warm welcome to all of you, and then enjoy the webinar. Thank you very much, Dr. Sharon. So over to you.
Thank you very much, Dr. Shandorf. So we would want to invite next Dr. Med Esther Ej Kwache to start us off with an opening prayer, and then we can kickstart the meeting. So Dr. Med Esther Ej Kwache. Esther, please, if you're on the call, just unmute and then give us the opening prayer, please. Okay, so it looks like, oh, okay, Dr. Med Esther says she can't unmute. Esther, please try again, please.
All right. Good afternoon, everyone. Good to have everyone here. Shall we share a word of prayer? Sharon, please, can I be heard?
Yes, please. We can hear you clearly.
Okay, all right. So let's have a word of prayer. Father, Lord, we thank you so much for this afternoon. We are so grateful for the gift of life and for the strength that you give us to go about our daily activities. Father, we pray that you be with us throughout this discussion. Let it be a fruitful one. Let the meeting be successful. And then at the end of this meeting, help us to make impact in our various endeavors so that we'll be profitable to everyone around us, especially the kids that have been entrusted in our care. Thank you so much for everything. In Jesus' name, we have prayed. Amen.
Amen. Amen. Amen. Thank you very much, Dr. Med Ej Kwache. So my name is Dr. Sharon Ogbebiche, and I will be moderating today's meeting. I'm currently the Greater Accra Regional Organizing Secretary of the Pediatric Society of Ghana, and also a pediatrician at University of Ghana Medical Center. And hopefully you join me from the beginning to the end, and hopefully no one drops off before the meeting because it promises to be a very exciting meeting for the day. So we'll go right to it. Our very first presentation. So our main presenter for today's webinar is Dr. Ahmed Nanama Ananibenfo, and she'll be speaking on the topic Beyond the Golden Glow, Early Recognition, Investigation and Referral for Prolonged Jaundice in Units in Ghana. Dr. Anna Nebenfo is a passionate pediatrician at the Department of Child Health, Kolebu Teaching Hospital. She's also a member of the Ghana College of Physicians and Surgeons and currently holds a master's degree in public health with a focus on epidemiology and disease control. She's currently a fellow in training in general pediatrics with a growing interest in pediatric gastroenterology and nutrition. She's actively involved in the department's quality improvement unit, where she leads initiatives aimed at improving patient safety, clinical efficiency, and ethical practice. Her professional interests span clinical research, medical ethics, digital innovation, and health system strengthening. And it is driven by a commitment to making child health care in Ghana more equitable, efficient, and future ready. Outside of her professional life, Dr. Anna Nebenfo is a devoted wife, proud mother of four. She enjoys traveling, exploring new places, and has recently developed a passion for keeping and caring for aquarium fish. Please join me in warmly welcoming Dr. Anna Nebenfo for today's presentation. Dr. Anna Nebenfo, over to you, please.
Yes, please. Thank you very much, Sharon, for the presentation or the introduction. Unfortunately, my fishes have all died, so I'm yet to develop or get a new hobby moving forward. I'll let you know when I do. Let me see if I can share my slides. Okay. Please, can you see my screen?
Yes, please.
Okay.
Yes, please.
Okay. Just putting it in slide mode. Okay.
Okay.
Okay. Oops.
Okay, we can see it in slide mode now.
Okay. Thank you very much, Sharon, for the introduction. And I want to say a very big thank you to the Pediatric Society of Ghana for giving me this opportunity to present this topic. This is actually one of the areas or topics that is very dear to my heart because of my practice. I see a lot of babies coming in with prolonged jaundice. And I hope that at the end of the presentation, I would have empowered us as healthcare professionals to look beyond the glow so that we can early recognize, investigate, and refer babies with prolonged jaundice in Ghana. So I want us to take a little journey. When I was preparing these slides, I decided that I will not let it be a boring lecture, but something that would inspire and encourage us to want to investigate and early recognize babies with prolonged jaundice. Most of you recognize this picture at the Bree Botanical Gardens, and just like every journey, when you begin a journey and you do not know much about the route you are on, it's always quite difficult. But when you have someone holding your hand and giving you all the tips, it makes the journey easy. So I want all of us this afternoon to take this little journey to know more about prolonged jaundice in infants. So we'll first address what the problems are. I want to present baby KB and her mother to you this afternoon. We actually saw this baby at the Pediatric Gastroenterology Clinic a few weeks ago. Mother noted that the baby had become jaundiced in week 1 of life, and she went to several health facilities as well as the child welfare clinics. And she was reassured severally that the jaundice will resolve on its own and she should just continue breastfeeding. When baby was 4 months old, mother noted that the abdomen was getting distended and the baby wasn't growing as well as she was growing earlier. So she took the baby to another facility where an abdominal ultrasound was done, and the baby was diagnosed with biliary atresia. By the time the baby came to our clinic, the baby had already developed signs of chronic liver disease. So I want to ask ourselves these questions. Do you think we as healthcare professionals we as a healthcare system, did we fail baby KB and her mother? And what do you think we could have done differently? I want these two questions to be at the back of our minds as we go through these slides. And then as we go through, please see if you can get answers to these questions. So one will ask, why should we talk about prolonged neonatal jaundice? I must congratulate the Pediatric Society, especially for a good campaign last month. We did a good job when it comes to advocacy for newborn jaundice. But I feel that prolonged neonatal jaundice was a bit put to the hindsight. But whatever it is, I believe that this is an opportunity for us to make some noise about prolonged neonatal jaundice. So today we'll find out why we should talk about it. We should remember that most babies present late with prolonged neonatal jaundice. And just like baby KB, although they would come, sometimes they may present late, and this results in delayed diagnosis, reducing their chances of successful treatment. Also, there's a low level of awareness, especially amongst us as healthcare workers and caregivers. And this leads to misdiagnosis and delayed referrals, leading to poor infant outcomes and complications. And it may surprise you that gradually worldwide, this is becoming a silent public health threat, especially in lower and middle income countries, and eventually robbing a lot of children of healthy futures and families of hope. And some of these interventions or treatments are very simple. Once it's implemented early, can help save the lives and livers of these babies. So one will ask, what is prolonged neonatal jaundice? So as the term says, it is jaundice that persists or that is prolonged. So for a term baby, once the jaundice persists beyond 14 days of life, and for preterm babies, once it persists beyond 21 days of life, you can say the baby has prolonged neonatal jaundice. It affects about 2 to 15% of well breastfed babies at week 2 and about 9% at week 4 of life. And we should take note that prolonged neonatal jaundice is actually a clinical sign and not a disease. So please do not make a diagnosis of prolonged neonatal jaundice, but you need to find out the cause of the prolonged neonatal jaundice. And that is why I even titled my presentation, Look Beyond the Golden Glow. So when you see a baby after 2 weeks or 3 weeks of life in preterm babies, ask yourself, why is this baby still jaundiced after this period? And then you can go further to investigate the baby. So before we go into it, we need to classify prolonged neonatal jaundice, and we classify it into 2. But before you can do this classification, I've put an attention note here. You should be able to fractionate the direct bilirubin. That is how much direct bilirubin is in the blood of the baby. And you do this by dividing the total direct bilirubin over total bilirubin and express it as a percentage. So after you do this, if you realize that the direct bilirubin is more than 20% of the total bilirubin, then this is known as conjugated hyperbilirubinemia. But the preferred term is neonatal cholestasis because that shows you where the problem is and how you should tackle it. If you do the calculation or you fractionate it and you realize that it's less than 20%, then it is known as unconjugated hyperbilirubinemia. So please just take note of this classification so that anytime we have a baby, we fractionate our direct bilirubin and categorize the baby under neonatal cholestasis or unconjugated hyperbilirubinemia. So now let's look at the pediatric GI clinic. I collected some data of babies we have seen with prolonged jaundice over the past 3 years. And in all, we have seen about 103 babies who came with prolonged or who were referred to our clinic with prolonged neonatal jaundice. And out of this, 84 of them were neonatal cholestasis, that is the conjugated hyperbilirubinemia. And 40 of them were confirmed biliary atresia patients. And we had a chunk of them being missed biliary atresia. And it's quite sad, as Dr. Shandov said, to see that babies are being missed, especially for a condition which is surgically treatable. Looking at the babies that we saw, majority of them were referred after 6 to 8 weeks of life. So meaning referral is still late, and that is a major concern. Some of the babies had also visited several health facilities before they were referred to Kolebu. And most of the time, stool color was not documented in this referral letter. So please let's take note of some of the concerns or issues here. So now we will go and we'll look into unconjugated hyperbilirubinemia and identify some of the common causes. The first is hemolytic disorder. So remember, during the early neonatal period, you may have a baby who may have resource incompatibility or ABO incompatibility, or even G6PD deficiency. Sometimes these babies can have prolonged jaundice, which is mainly unconjugated. There are also infections when you have your neonatal sepsis or the baby has neonatal sepsis, urinary tract infections especially. There have been several babies who've been referred with prolonged jaundice, the unconjugated type. We do a urine culture in our clinic and we pick up urinary tract infections. Once you treat them, the babies improve and then the jaundice clears gradually. And we have the torches infection or the congenital infections as well. And just this Tuesday, we diagnosed the baby with CMV disease and started the baby on antiviral therapy. So these infections are common and do exist. For endocrine causes, we have congenital hypothyroidism, which you also have to look out for in these babies. One significant group of babies that are at risk of prolonged jaundice is preterm babies because of the delayed maturation of their hepatic conjugation enzyme. So it takes a much longer time for them to be able to clear the bilirubin. And then finally, we have breast milk jaundice, which is actually the commonest type of unconjugated hyperbilirubinemia, but this is a diagnosis of exclusion, and you will need to rule out all other causes before you can stick your neck out and say the baby has breast milk jaundice. Now let's look at the other side, neonatal cholestasis. What are some of the causes? Remember, cholestasis means slowing of flow of bile in the liver. So it can either be due to a problem with the liver or a problem with the outflow of bile out of the liver. And when you look at the hepatocellular problems or hepatocellular conditions, we have neonatal hepatitis. And still under this, we have neonatal sepsis, UTI, and torches. So these three conditions can actually give you what we call a mixed picture or can give you either conjugated or unconjugated alone. There are also metabolic disorders, of which galactosemia is quite common. And then we have endocrine and genetic disorders as well. For the outflow or obstructive causes, we have extrahepatic causes, and the commonest is biliary atresia, which we'll talk later about later in the presentation. And then we have also intrahepatic causes. So just anytime you have a baby coming to you with prolonged jaundice, find out the direct bilirubin first, and then you can categorize the baby. And then once you categorize the baby, you know which of the common conditions or infections you are dealing with, and you can investigate the babies accordingly. So now that we've looked at the problems, let's look at some of the solutions. I want to first say that the solution starts with you. That is everyone on this call this afternoon or this evening listening to me. We can make a change and we can make things better for our babies. And tackling prolonged neonatal jaundice does not just lie at one person, actually a multifaceted approach. We need more training for our healthcare workers. And I'm happy that I've been given the opportunity to do this. And I know that I'm impacting some knowledge to everyone on the call. We also need to give more caregiver and community education, send the word across, let them know about prolonged jaundice, let the mothers know that if your baby is jaundice after this period, please bring your baby to the hospital to be properly investigated and treated. And we also need to strengthen our referral pathways. Through the problems, you noted that most of our babies were coming in late, and this, once we improve it, we can catch our babies early and then treat them. One will ask, how do we recognize these babies? So you are in the consulting room, you are in the labor ward or the child welfare clinics, and you have a mother reporting to you with a baby whose jaundice has prolonged. You need to be able to properly identify what the risk factors are and what the causes are. So the first thing you have to do is to take a detailed history. Ask about how long the jaundice has been there and its progression, how it has worsened, and even the tinge of the jaundice may also give you a clue. The antenatal and birth history is very important. You need to find out if the mother was treated for any infections during the pregnancy, if the mother has any form of was treated for any congenital infection that may put the baby at risk of picking up any infection. Find out about even whether the baby was born preterm or not. As we mentioned, prematurity is a risk factor. The feeding and growth history is also very important, whether the baby is exclusively breastfed or on formula feeding, whether the baby even tolerates the feed, and the growth of the baby is also very, very important. Your family history, you need to find out whether the parents are related in any way, and also if the mother has lost any babies. Some of these genetic and metabolic disorders come with early infant deaths or even spontaneous abortions. After you are done taking a detailed history, you have to take a good look at your baby. Most of the time, these babies come, they are very happy, bubbly, healthy looking babies with just yellow eyes. So you really need to take your time and pick out very important signs that can help you in your diagnosis. The growth of the baby is very important. The nutritional status of the baby as well. Touch the abdomen, palpate it, and see if you can palpate a liver or a spleen. Look for the urine color, because dark urine is actually a risk factor for neonatal cholestasis. The stool color, if it's pale, then it's something to be concerned about. And you need to look for signs of liver dysfunction. So if the child maybe is bleeding from puncture sites, has small bleeding on the skin called petechiae, you need to identify all this. And these are all red flags that will help you to manage the critically ill or the babies that need attention. So we've put together this simple algorithm to help all of us navigate our way through investigating a baby with prolonged neonatal jaundice. So as I mentioned, once the baby is term and is 14 days and above, or preterm and older than 21 days, you have to state that this baby has prolonged jaundice. So you take a detailed history and examine the baby, looking out for all the issues that we've spoken about. Then you fractionate your direct bilirubin. So if you do and it's unconjugated, then you move to part 1. And remember the courses that we spoke about. So that will help you to know which of the investigations to carry. So you may do a blood group and Coombs test for the baby, a full blood count. Remember hypothyroidism, so you would want to do a thyroid function test. Remember urinary tract infection, so you would want to do urine culture, and then even septic screening if the baby is unwell. And then you move on as follows. On the other hand, if it's more of a conjugated picture, or neonatal cholestasis, you also know what you are thinking about. You are thinking about biliary atresia. You are thinking about urinary infections, urinary tract infections, neonatal sepsis. Then you also investigate along this line. Remember, abdominal ultrasound is actually at the conjugated hyperbilirubinemia pathway and not the unconjugated hyperbilirubinemia pathway. So please, let's take notes. And then you should always be alert of the red flags. So these are some of the red flags that I've highlighted, that anytime you see a baby with any of these, please again, quickly investigate and refer this baby if there need be. If the baby has pale stools, if the urine are dark and stains the diaper, or if the urine is dark and stains the diaper, look for signs of sepsis in the baby. The baby is febrile or has a very high temperature, is not feeding well, maybe having seizures, is lethargic, is not as active as before. Please, this is a red flag, to admit this baby and investigate. If the baby is failing to thrive, is not gaining weight as much as you expect, you palpate the abdomen, you realize there's a liver or a spleen, you are thinking about a congenital infection. So you quickly have to investigate this child. Or as I mentioned earlier, these bleeding abnormalities. Please again, remember that parents are not reliable observers of stool color. I've been in several consulting rooms where we have clinicians and other healthcare workers asking the mothers about the colors of their baby's poop. Unfortunately, sometimes when these mothers come, they may not tell you the exact color that you need to know, or they may even be too anxious to give you a very reliable answer. So we as healthcare workers, we are better at detecting pale stools in babies. So please again, look at the poop of your baby when the baby comes to you, whether in the consulting room or at the child welfare clinics or even on the ward. Because sometimes the diagnosis is just a little finger away. Sometimes you open the diaper, you might not find any stool, but please just stick your little finger in the anus and then note the color of the stool. Is very, very important, because that is maybe the first clue of the diagnosis for you. So I want to give a little viewer discretion. Please, anyone who is eating any custard or groundnut soup, please take notes. I'm going to share some pictures of some poop. So please, viewer discretion is advised. So this is what we call an infant stool color chart. And you can see it's a card that gives you the different colors of stool of babies. And the ones above, 1 to 3, actually are pale looking stools. So these are the stools that when you see any baby passing, you should be concerned and you should quickly refer this baby to the specialist hospital. From 4 to 6, these are usually normal colors. So you have the different shades of yellow and even green stools sometimes. And these cards are actually given to parents when they are being discharged in most of the developed countries around the world. And the mothers or parents are educated to examine their baby's stool color every day. And once they note that the baby's stool are abnormal, they quickly should rush their babies to the hospital. And I believe it's one of the simple cost-effective tools that we can actually use to empower our parents at home to be able to quickly detect abnormal stool color. And I believe introducing this card in our healthcare system, at the child welfare clinics, at the labor wards before mothers are discharged, can revolutionize detection of biliary atresia in Ghana. So now I'll talk about one of the common surgical causes of biliary atresia. And it's so sad when you see a baby coming very late with biliary atresia and there's nothing you can do about it. And that is why this slide, I titled this as A Race Against Time, because every week or every day the baby's diagnosis is missed, it's actually a time, or it leads to more time being lost for us to help save this baby. And when we say biliary atresia, it just means that the duct or the plumbing system outside the liver is fibrosed and obstructed. And this is actually a progressive condition. So it takes time for the problem to actually build up. And it's one of the most common surgically correctable causes of neonatal cholestasis. And it's often seen more in females compared to male infants. And early recognition of this condition is very critical, because once the baby is recognized early, the surgery, which is Kasai procedure, can be done early enough for this baby to save the life of the liver. And the earliest time, or the preferred time, that we want surgeries to be done is about 6 to 8 weeks. And we know that even if it's earlier, it's better for us, because then we're able to save baby's liver. So what should you do, or when should you suspect biliary atresia in any baby? Remember, once the baby comes to you with prolonged jaundice, you look at the stools are pale, and the baby has dark urine. Please again, make a diagnosis of biliary atresia until otherwise proven. If there's a need to investigate, you investigate and quickly refer this child, because it's a ticking time bomb, and the more we delay, the more problems we cause. I keep on talking about timing. And why does timing matter? Because when the surgery is done early enough for these babies, the chances of surviving, or the liver surviving, is very, very high. When the surgery is done before 6 weeks of life, the liver actually has a 75 to 85% chance of survival, compared to surgeries being done after 3 months, where the chances is less than 25%. And in the case of baby KB, when the baby came, baby had already developed chronic liver disease. So we shouldn't let these babies get to that stage. So there was a study done by Dea Samoa et al. In Kolebu Teaching Hospital, the pediatric surgery ward, or the pediatric surgery unit, of all babies who had undergone the Kasai procedure. And I want to share some of the findings with you. So they did the surgery for 31 babies over, I think, about a 5-year period. And out of this, 71% of them were female. The minimum the minimum age the surgery was done was 5 weeks, and the maximum age was 20 weeks, which is about 5 months. But the mean age for most of these babies was 10 weeks of life. So you can see that the window is about 6 weeks. And if we are doing our surgeries after 10 weeks, then we know that the chances of these babies' livers surviving is very, very low. And unfortunately, only 9.7% of these babies actually had the surgery before 8 weeks of life. It means that a whole chunk of them had the surgery after 10 weeks. After the surgery, they followed the babies up for 6 months, and they realized that only 5 of them had a successful procedure. And at the end of the 6-month period, more than half of these babies had developed chronic liver disease. So I keep on saying that biliary atresia is a diagnosis of time is of the essence, and that the earlier you refer these babies, the better for them. Sometimes we also want to rely on abdominal ultrasounds, and there's been instances where parents have had to go and come back for weeks because they couldn't afford to do an abdominal ultrasound. Let's remember that sometimes in the early stages of biliary atresia, the ultrasound may be normal, and the findings of diagnosing biliary atresia may be or can be operator dependent. So depending on the experience, or how much, or who is even doing the ultrasound, you may or may not pick up signs. And the fact that the scan will tell you that the gallbladder is small or absent is not always diagnostic. Ultrasound has a sensitivity of about 75 to about 80%. So it's not all the time that we should rely on abdominal ultrasound. So please take note of the important red flags: yellow baby, pale stools, dark urine, suspect biliary atresia until otherwise proven. So once you've been able to make a diagnosis, these are just some simple general management steps that you can put in place to help manage babies with prolonged jaundice. Remember, if it's a cholestatic jaundice, most of these babies may have fat-soluble vitamin deficiency, so you may need to supplement them with some of these fat-soluble vitamins. They would really need nutritional support, so they should continue breastfeeding where possible and ensure that the babies are taking in very adequate quantities or adequate amounts of calories. You also need to identify and treat complications. If the baby has hypoglycemia or is dehydrated, please promptly identify and treat them. And as per the algorithm, you need to complete the essential investigations. So when they come, you may not give all the investigations to them at the same time. You can actually stagger it so that you can start off with the more common ones. If the results comes and is negative, then you can move on to the more highly specialized one because of the cost in some of these investigations. An urgent referral. Once you see a baby with prolonged jaundice, you're able to quantify the direct bilirubin. Please refer the babies if the need be. So I have spoken a lot about sad stories, and it looks like the picture has been a bit gloomy. But please remember that happy stories do exist. And this is one of our patients at the GI clinic. She's Miss EA. Her mother actually noticed that baby was jaundiced when baby was about 2 weeks of life, and immediately she reported to the hospital. The pediatrician who saw noted the pill stools, and the liver function test was done early. And the baby was referred in about 2 weeks to Kolebu and had the surgery done. And in a few weeks, the jaundice cleared, the stools became pigmented or yellow. And now the child is now 4 years. She's in kindergarten. And when she comes to the clinic, it's always a joy to see her. So what are some of the actions that you can do you see in Miss EA stories that you think were taken early? And remember the story of baby KB. What do you think we can do to make these stories better and help save the lives of these babies? So when we're able to promptly identify, investigate, and manage these babies, what are some of the benefits? Remember, for the babies, there's a better chance of survival, they develop fewer complications, and they grow and are happy. For the families, there are fewer hospital admissions, the financial burden is reduced, and even the emotional stress. There's been several couples who have divorced because their babies had chronic liver disease and all the advertent emotional stresses that come with this. And even for us as healthcare workers and healthcare facilities, we can better coordinate patient care, and then we use our limited healthcare resources better and eventually improve child health outcomes. So these are a few recommendations I wish to share. If the algorithm can be introduced into clinical care for assessing babies with prolonged jaundice, if we can actually generate a stool color chart for our babies in Ghana and then share them to mothers when they are going home, or even have them on the walls in the labor ward or child welfare clinics, ask mothers to take pictures or even scan them and put them on their phone. And every day they should look at it and make sure their baby's color, poop or stool colors are not pale. We also need to go on to educate our parents about prolonged jaundice before they are discharged. And I'm happy that I've been able to have this session with you. But as we go forward, if we can organize yearly CPD during the Jaundice Awareness Month for healthcare workers on prolonged jaundice or neonatal colitis, that would be very, very great. And if we can strengthen referral pathways to tertiary facilities, so that you know that I'm in this CHIPS compound, or I saw a child at the child welfare clinic, this is what I have to do to refer a child with prolonged jaundice. So just a few take-home messages for us. Let's remember that any baby who comes with prolonged neonatal jaundice, please do not ignore this baby or reassure the mother that it's going to go away. Every baby should have their serum bilirubin checked and fractionated early so that you'll be able to know whether it's an unconjugated picture or neonatal cholestasis. And if you forget anything about today's presentation, please don't forget this, my formula. Yellow baby plus pale stools plus dark urine is biliary atresia until otherwise proven. And let's remember, early referral saves lives and livers. So please see the stool, check the bilirubin, and save the life of our dear babies. I want to acknowledge the pediatric PSG gastroenterology and nutrition subspecialty group, my mentor and boss, Dr. Taiba Afa, and everyone who helped me with my presentation. Thank you very much, and over for now.
Thank you very much, Dr. Ananebimfo. Dr. Wabiche.
Yes, please. Sorry, I was trying to unmute. So thank you very much, Dr. Ananebimfo. That was a really enlightening presentation on prolonged neonatal jaundice. And I think we have heard how she has highlighted why we need to recognize it early, refer early, so that we can help save a baby's life. Please, are there any questions? If you have any questions, kindly feel free to put them in the chat box. You can also raise your hand and we would go ahead and unmute so that you can ask your question. Okay, so whilst we wait for any question, I would like to highlight the top 5 key messages.
Sharon, I think Dr. Jiman's hand is up, please.
Okay, Dr. Jiman, please go ahead and unmute and ask your question, please.
Hi, Doc. That was an excellent presentation. I have a quick question. It appears vitamin K is not in any of the multivitamins available in the country. And I want to find out, how you give vitamin K, how you supplement vitamin K in these babies.
Thank you very much, Dr. Ajiman, for the question. Yes, so we do not have oral formulations of vitamin K in the country. So what we do in the clinic is we give the IV vitamin K, that is the one that comes in the ampoule. We give it orally to the babies, and it's been found that the bioavailability is the same as the oral formulations. So for neonates or infants, we'll do 1 milligram if it's prophylaxis. And if we need to do higher doses as well, we can. But it's the same IV that is giving that we break. And then so the mothers break it and then they give it to the babies orally to take. And it really helps. It has helped us to manage most of our babies who come with abnormal INR or clotting profile. So the IVs can be used orally. Thank you.
Yeah, excellent. It can be used. Thank you so much.
Thank you too.
Thank you very much. Please, do we have any more questions in the chat box? Any questions? Okay, so just to briefly highlight my takeaway messages, and I'm sure we all have our own takeaway messages or key messages from the presentation. So I was glad to hear that prolonged neonatal jaundice is a warning sign, but not a diagnosis. I think it is one of the central messages of the presentation. It was also good to hear that biliary atresia is a race against time. And we have demonstrated that with the story of the babies Dr. Ananebimfo shared. And also that early recognition and referral can change a child's entire future. And this is the very key message. So as our theme for the month when spot it early, treat it right, it's very important that we recognize these cases early and treat it right. And I was also going to. I liked the part about not asking. I think all in all, in the consulting rooms, we are so used to asking, or even in the clinics or at the child welfare centers, we are so used to asking, "Mommy, what's the color of your baby's stool?" So another take-home message today is that don't rely on the mother's answer when you ask that question, but try and look at the stool yourself. So we have a question from Yushao Adam. So Yushao, please, you can unmute and ask your question, please.
Okay. Good afternoon. Thank you to everyone. Hello, I hope I can be heard.
Yes, please, we can hear you, Yushao.
Okay. So I want to thank Doctor for a wonderful presentation. Likewise, I equally learned a lot from this presentation, in the sense that they're relying on mothers' history to just ask of the stool and then try to also make sure that the stool colors being made available to at least all facilities such that we'll be able to see, and then perhaps at the point of discharge for mothers to equally use it, very important. I've also learned that during the history taking, we should at least do in depth, not just the mother telling you that I've realized that Jaundice appeared on this day, and you won't do in depth history taking or analysis and then turn them away. So perhaps if the bilirubin level was checked in the initial phases, this child wouldn't have developed these complications. My point is also an advocacy or a plea. Dr. Sharon and the team, if more advocacy can be placed such that facilities can get the firefly, there are instances where someone's bilirubin levels will be very higher, and then if not firefly machines to bring the bilirubin totally down is going to be a very big issue. So if at least major facilities have firefly machines plenty, at least the awareness creation as we are doing, and then the equipment to deal with this condition, if we have it, I think it will be of more help. Thanks very much for the wonderful presentation. Thank you very much.
Thank you very much, Yushao Adam. Thank you so much for your suggestions and for your points. We'll note them down. Okay, so we have one question in the chat box, Dr. Anani Benfo. Please, what happens after delivering a baby and then realizing that the child is jaundiced? Do you still go ahead? I'm guessing is, do you still go ahead with other vaccinations like vitamin K and TT? I mean, other medications like vitamin K and TT. That's tetanus. I don't think we give tetanus to the newborn, so I'm guessing it's just vitamin K.
Is it
Yes, please.
just vitamin K, or he means vaccinations like the EPI schedule?
Probably we can touch on both. Can we go ahead and vaccinate babies with neonatal jaundice? And then also at birth, if you notice a child is jaundice, do you still go ahead to give the vitamin K? Maybe we can touch on all that.
Okay, so soon after delivery, once you notice that the baby is jaundice within the first 24 hours of life, you can still go ahead and give the vitamin K. But most of the time, jaundice within the first 24 hours of life is pathologic or abnormal, and this baby would require urgent investigations and phototherapy. But after the newborn period, if the baby is jaundice and maybe has prolonged jaundice, this baby can still receive his or her vaccinations according to the EPI, so 6 weeks, 10 weeks, etc. But at each stage, I think you can give the baby the immunizations or the vitamin K at birth. But sometimes, even for babies with prolonged jaundice, if they come with abnormal bleeding, sometimes even on admission, you can give IV vitamin K to help with the abnormal bleeding. So it's possible. Thank you very much.
Thank you very much, Dr. Nanibinfo. Please, any other questions? If not, we move on to the next session of our webinar for today, which is the panel discussion. Okay. So any other questions can be put in the chat box and will be answered towards the end of the webinar. So we'll be moving on to our panel discussion, and I would like to introduce our panelists for the day. So we would hear two parents share their stories and their experiences, and then we'll take up we'll have a few questions for our panelists. Please feel free during the discussion to also drop any questions you have for the panelists in the chat box, and we would ask them for them to answer. So our very first panelist is in the person of Dr. Kwabna Onwuna Ajiman. He is a distinguished neonatologist at the Greater Accra Regional Hospital, where he leads the care of some of Ghana's most vulnerable newborns. He holds an MD from Lviv State Medical University, a membership from the West Africa College of Physicians in Pediatrics, a certificate of neonatology from Tygerberg Children's Hospital in South Africa, and is a fellow of the Ghana College of Physicians and Surgeons. With extensive experience spanning Ghana, South Africa, and the United States, Dr. Ajiman has dedicated his career to improving outcomes of preterm and critically ill newborns. His research focuses on implementing evidence-based neonatal interventions in low-resource settings, and he has contributed significantly to neonatal research and quality improvement initiatives, both locally and internationally. He is also an active member of the African Neonatal Association and the Pediatric Society of Ghana. Please join me in warmly welcoming Dr. Kwabena Ajiman. So, Dr. Ajiman, please, if you are around, you can kindly put on your video and join in the call. Thank you. So, our very next panelist is in the person of Miss Fatima Sule. Fatima is a state-registered nurse and neonatal nurse with over 15 years of experience in maternal and newborn healthcare. She currently works in the neonatal intensive care unit at the Greater Accra Regional Hospital, where she is actively involved in neonatal resuscitation, newborn care, staff training, and the management of critically ill neonates. She holds a certificate in neonatal nursing from the Ghana College of Nurses and Midwives and has received advanced training in neonatal resuscitation, transport, and emergency care. Fatima is passionate about improving newborn outcomes and enjoys cooking and listening to music in her leisure time. So, Fatima, if you're on the call, kindly put on your video and let's see you. You are very welcome. Please, is Fatima on the call? Yes. Fatima, we can't hear you. Fatima.
Hello, good afternoon.
Hello, good afternoon. You are welcome.
Thank you.
Thank you. So our next panelist is in the person of Mrs. Dora Jones Yedu. She is a highly accomplished public health nursing professional with over 19 years of clinical practice experience, including 18 years dedicated to preventive health services. She currently serves as a nurse manager at the Cape Coast Metropolitan Health Cape Coast Metropolitan Health Directorate and has previously held several leadership positions, including Acting District Director of Health Services and District Public Health Nurse. Mrs. Yedu holds a Master of Public Health from GIMPA and has devoted her career to strengthening maternal, child, and community health services across Ghana. Beyond her professional work, she enjoys writing books and singing, reflecting her passion for education, creativity, and community engagement. So, Auntie Dora, Mrs. Dora Jones Yedu, please, if you're on the call, kindly unmute and let's see you. Okay, so we'll give some time for Auntie Dora to try and get back on the call whilst I go ahead and introduce the next panelist. So the next panelist we have is Mrs. Diana Nyako, who is a highly experienced senior midwifery officer with 16 years of dedicated service in maternal and newborn healthcare. She currently serves as the head of the maternity department at Shai Osudoku District Hospital and is pursuing an MPhil in midwifery at the University of Ghana, Legon. With extensive expertise spanning antenatal, intrapartum, postnatal, and neonatal care, Mrs. Nyako is passionate about improving maternal and newborn outcomes through quality care, mentorship, and continuous professional development. Her commitment to the excellence has been recognized with both the district and regional Best Nurse or Midwife Award in 2022. A strong advocate for newborn health, she has a personal passion for the care and well-being of babies. Outside her professional duties, she enjoys listening to music and dancing. Please join me in welcoming Mrs. Diana Nyako. So, Auntie Diana, if you're on the call, kindly unmute and also put on your video so we can see you.
I'm glad I'm here with you.
Okay. Thank you, Auntie Diana. And then our final panelist for the day is in the person. So she is a parent and is in the person of our next speaker is a parent and is a vibrant and outgoing professional who loves connecting with people and building meaningful relationships. She's a global tech event coordinator with Sanfair Events, a French company specializing in international technology events. She's also a sports enthusiast who enjoys several activities, including lawn tennis. She's also a devoted wife and mother of two. Her personal experience with gestational diabetes during the pregnancy, whilst pursuing her second degree at the University of Ghana, Legon, as well as having a child who was managed for prolonged jaundice, has given her unique insights into the realities of pregnancy, neonatal, and maternal health. Please kindly join me in welcoming Mrs. Sylvia Owusu. So, Sylvia, if you're on the call, kindly unmute and share your
Hi,
video briefly.
everyone.
Okay. Okay, thank you. So I think we are left with one panelist, Auntie Dora. So whilst my co-executives work on getting Auntie Dora to join in, we would want to start our panel discussion. On this note, I would want to invite all the panelists to put on their videos so that we can start our panel discussion. We would have another mother share her story in the middle of the discussion. But for now, we would want to start with some questions. Okay, so Dr. Ajiman, you are very welcome to today's discussion. So I have a question that I would like to ask all our panelists. What is the single biggest reason babies with jaundice in Ghana are still presenting late, despite jaundice being a very common condition? In your opinion, Dr. Ajiman, what is the single biggest reason babies in Ghana are still presenting late, despite jaundice being a very common neonatal condition?
I think one of the pure problems we have is to do with healthcare practitioners. I've always been saying we looked at all our babies who presented with severe jaundice, and then we realized over 95% of instances the delays were in hospital. So I think we need to do in-house cleaning and in-house awareness first. Ghanaian parents are wonderful. They will always, if they see any red flags, they will always come. But it's with the hospitals. And one of the major problems we have in the bigger hospitals are the early discharge rates we are seeing, especially from normal vaginal deliveries. Most babies are, if you find you are discharged less than 12 hours, and these are times that breastfeeding is not established. A major component we see are babies who are dehydrated. Irrespective of the cause of your jaundice, if you are dehydrated, the jaundice gets worse. So, we now call it, suboptimal intake jaundice. And mothers are quickly discharged. Breastfeeding techniques are not well coordinated before they are discharged. And that early review, we seem not to get it. And so I think that is one of the major contributing factors why we still see jaundice to this level. So I think I'll be proposing we have to really, really look at postnatal discharges and then how we coordinate reviews.
Okay, thank you very much. So I'd also want to go to neonatal nurse specialist, Fatima. So Fatima, in your opinion, what is that single or what is the biggest reason you think babies are presenting late?
So to me, I think education is one factor. Even though we are educating people, there are few who still want to think about the cultural and beliefs and all those things. So it makes seeking care delayed. That's one main factor. Beliefs and cultural factors are one issue.
Okay. Okay. And then Auntie Dinah, please, I would like to come to you. Since you deliver the babies and give them to us, what do you think is the
Well, fortunately for
the single biggest
I
reason
work
or
in a
the
district
biggest reason?
hospital.
Okay.
I work in a district hospital, and unlike the regional hospital and the tertiary hospitals, we actually would discharge after 24 hours. And so you would have the time to look at these babies prior to discharge. However, our home doctors are a bit of a challenge when it comes to neonatal jaundice, because you tell these mothers, when you go home, look out for this and look out for that. They're able to identify all right. But getting them to come to the hospital now becomes an issue, because the home doctors will give them home remedies. Oh, wait a little. This is really nothing. During our time, we did this and we did that. And because of that, they end up coming at a later time when a lot of complications have already set in. That's what I think. Thank you.
Thank you very much. Thank you. So I think whilst we wait for Auntie Dora to still join us, unfortunately we are at capacity. And so for those who will still want to join, they can join via the Zoom link. We are still trying to get Auntie Dora to join us. But then Dr. Ajiman, please, I would like to ask, where are we losing the babies the most? Is it from recognition? Is it referral? Is it transport? Or is it treatment? Where are we losing the babies? Where is the gap? Why is it that they are still not presenting on time and we are having babies with prolonged jaundice go for weeks, even months, without any health interventions?
Well, I don't know, but there are two different things. When we talk of babies with unconjugated hyperbilirubinemia and those who have prolonged jaundice, who will tip to the conjugated. With the conjugated, I think
Dr. Jaman, please, is it possible to increase the volume
hello.
a bit?
Yeah,
Yes,
I'm
yes,
saying, can you hear me now? Yes,
yes,
I'm
please.
saying that with this, we have two areas we are discussing now. One will be the babies who present very early with the hemolytic disease, and we have those who present with prolonged. I think I'll start with the prolonged, and those of us who work outside tertiary centers where we need referrals. It's a major problem when you pick up a baby with prolonged jaundice. I think centers, the gastroenterology centers, should be opened up more and be able to get early referral for these babies. And at times you do all labs and everything, you are confident, they get to the they get they don't get enough. I mean, like the booking dates are too long for them. And we will have to sit on these cases for a longer time. So I think the referral pathways are very important. And Kolebu Gastro unit should be able to help us that when we pick up these cases who are prolonged, priority should be given to these referrals and action taken as early as possible. Because parents waste a lot of money. We do scans and all this. They get to these centers, they have to repeat everything. And that's quite a big of challenge for parents and unnecessary time wasting. So we have to look at that coordination very well.
Okay. Thank you very much, Dr. Jiman. Thank you. I want to go to Fatima. Please, if you have any questions along the line, please feel free to drop it in the chat box and then we would go ahead to ask. So Fatima, I would want to ask, what are some of the early warning signs that are commonly overlooked? What are some of the common early signs that are commonly overlooked, both for babies with unconjugated and conjugated? I think Dr. Anna Nebenfo did a very good job giving us some insight into the signs that are commonly overlooked, particularly with babies with conjugated jaundice. So with the unconjugated, what are some of the common signs that we overlook?
Yes, she did. So for the warning signs, the early ones, you could see a baby whose sclera is yellow, the baby's skin is yellow, the mucous membrane of the mouth could also be yellow, especially in a dark pigmented baby. So that is one of the physical signs. You could also see urine, dark colored urine, coca colored urine. And then the behavioral factors too. You may identify the baby as being lethargic, very weak, does not do anything. Even feeding becomes a problem. Baby does not latch to the breast. Baby has few diaper changes. We expect about 6 to 8 changes in a day, but a baby may come and they have just 3 diaper changes in a day. That is a sign that something is really happening. And you could also have a baby who has a high-pitched sound cry. This also signifies there's something really wrong with the baby. So jaundice early signs could look like these. Thank you.
Thank you very much, Fatima. Thank you. And then Fatima, back to you. I wanted to also ask, what are some of the barriers you think prevent escalation of concerns? So sometimes our parents are able to come in they are able to voice out their concerns. But what are some of the factors you think prevent escalation of these concerns? Because sometimes when they finally come in, they'll tell you, I did come in, I definitely told a doctor, a nurse, but then one reason or the other, they get lost in the system, and then you see them later with complications. What are some of the barriers you think are preventing the escalation? Thank you.
So firstly, we'll talk about knowledge gap. The knowledge of the healthcare professional is one factor. If the person doesn't know about the pathophysiology of jaundice, the person doesn't know about pathological jaundice, physiological jaundice, the baby is presented to the hospital on the first day of birth within the 24 hours, and baby looks yellow with the eyes, the sclera. And the nurse or a doctor who does not really have enough knowledge will tell the mother to go home and come back, go and feed baby well and come back. So with the knowledge gap, this is what happened. And also there could be poor protocols. You wouldn't have enough protocols on the ward to know that if I see this, what should I do? Any guidelines to follow, sometimes we lack it. And there could be also fear in the nurse. She feels when she escalates this, tell the doctor that, oh, there's a baby here who looks jaundice, and they come and the baby is really not jaundice. She feels she may be reprimanded or something. So that is also another factor. And there could be challenges, facility challenges. We know we have issues with our resources. So a facility that lacks phototherapy machine, that lacks labs, the turnaround for serum bilirubin is very long. It's a big factor. And also the staffing, nurse-patient ratio. If a nurse is taking care of about 20 patients, it's difficult to really follow up on the monitoring of the baby or even report on that kind of situation to the doctor. So these are some few factors.
Okay. Thank you very much. Auntie Dinah, please, would you want to add to that? Are there any points you'd want to add to that before I go to Dr. Anna Nibenfo, who has raised her hand, please? And Dr. Ajiman as well.
Okay, actually, I think that she has, in a summary, spoken about virtually all the things that I really want to touch on. So I think that's okay.
Okay. So Dr. Anna Nibenfo, Dr. Ajiman, I'll be with you. Dr. Anna Nibenfo, please.
Yes, please. Thank you. Thank you very much, Fatima. She's actually said a lot, most of the things I wanted to say. I think Fatima mentioned it. But the little I want to add is the information that we give the caregivers. Because remember, even especially for prolonged jaundice, some of the babies, they are fine, healthy, feeding well, gaining weight, and the only thing is that they are yellow. So sometimes the parents themselves feel that, oh, but my baby is not ill. Why should I be referred to another facility and all that? So we need to educate the parents very well to let them know that jaundice after this period is not normal. And although your baby is normal now, we still need to investigate this baby further. So apart from what Fatima said, I just wanted to add the fact that we need to also educate our parents and our mothers especially to be quick enough to report to the referral site, because sometimes they stay home not because they do not have this. Some like financial constraints may be one, but sometimes they just do not know how urgent or how important it is for them to report to the healthcare facilities early enough. So maybe we may need to add that education is very, very important. Thank you very much, Sharon.
Okay, thank you very much. Dr. Jiman, please, you wanted to add
A
something.
quick one. I wanted to just mention again on the laboratory testing. You know, I mean, color jaundice is so subjective, right? So hospitals should really, the main area is laboratory testing and to make a turnaround time. Most times, 1 to 3 hours, bilirubin should be ready and decisions will be taken. But where bilirubin results will span to the following day, parents will schedule an appointment 2 days, they never show up. So I think where we need to do is to get proper laboratory services. We have to really also invest in the non-invasive testing. The transcutaneous bilirubinometers should be readily available in postnatal wards and at clinics, so that, I mean, we know what we're dealing with, and then move on to do blood testing, and then probably whilst we wait for labs, we start phototherapy. So laboratory testing is an area we need to aggressively look out for. in most districts and tertiary centers.
Okay, thank you very much, Dr. Ajiman. Thank you. So we are still waiting for Auntie Dora. Unfortunately, our participation, the capacity is full, so she's still trying to get in. When she does, we'll have some questions for her. The questions in the chat box will come to you soon. There's also the CPD form that has been put in the chat box. Please make sure to fill it for your CPD points. So, Auntie Dinah, please, I would like to ask, how can continuity of care be improved? How can we improve on continuity of care? So we see these babies, we deliver them. Sometimes, in fact, most times they are lost to follow up. There are mothers who deliver and they don't even know that they have to come for postnatal review at all. So how can we improve upon the continuity of care, particularly for these babies?
I think that it's actually a collaborative thing that we can do. Working as a midwife or working in any hospital means that you do not have to work in silos. Once these babies are sent into the communities, there are community health nurses, there are public health nurses that are responsible for following up these babies. But then again, looking at the discharge processes in the hospital, the midwife would deliver the baby, discharge the baby after 24 hours if it's a vaginal delivery. And then there is no direct linkage of that baby to any community health nurse in the community, or even any public health person in the community. We only give them a review date, come back in 1 week time, give them the education, and then assume that they actually understand what we have said. So within that 1 week period, then they are on their own doing what they like. So I think that the linkage should be at discharge to the community through the community health nurses. Actually, there's this program that the International Health Partnership has rolled out, but they are doing that for only sick newborns. I think that if the nation takes that up, it would help. There is this follow-up form you fill for every baby that you discharge. Then a public health nurse picks it, maps the baby to a community health nurse wherever the parents lives, and then that follow-up is done. So you realize that such babies have somebody actually and checking on them so that if something is going wrong, they pick up. But unfortunately, it's not for every baby. And so if we are able to mimic what this program is about and then do that, I'm sure we'll catch these babies with neonatal jaundice early. And then we won't leave them just in the communities for the parents to do or take care of themselves however they want to. Thank you.
Thank you very much, Auntie Dinah. Thank you. Indeed, we need to be able to strengthen our systems so that we can help save all these babies. Just briefly, I would want to let a parent come in. So Sylvia, please, are you still on the call?
Yes, I'm here, Doc.
Okay. So Sylvia, please, if you don't mind, can you briefly share your story? We also have another mother online who was also not able to join the call. So after that, I'll call her and then she'll also share her story via speakerphone. But Sylvia, kindly go ahead and share your story briefly, and then we'll continue with our discussion.
All right. Hi, everyone. My name is Sylvia, as Doc said, and I had a baby who had prolonged neonatal jaundice. It started, I had my baby via CS at 38 weeks. And on day 2, I was told my baby was looking a little yellowish, so she needed to do phototherapy. So we ran the test, and then baby was put under the phototherapy for 3 days, and then we left with good numbers to the house. But fast forward 7 days later, I come back for review, and the pediatrician for my former facility. So I attended 2 facilities. So this is for my facility where I had the baby. Told me the baby still looks a little yellowish, so we needed to do more phototherapy for 24 hours. Or else we checked the numbers. So we did that and we were discharged because the numbers went down again. But whilst I was home, I still realized baby was not looking too good. She still was yellow. It was getting worse. Her gums, her eyes, her feet were all looking yellow. So we came back again 1 week later. So this is 2 weeks post-birth. We came back, they ran the bilirubin again, and then it had gone up way past what it was the previous time. So we were made to do photo again for 48 hours. So we did it again, and then we left with good numbers. So as we were home, I was so worried. Baby kept getting yellow. The yellow thing was not going. She was very sleepy. Even though she was eating, she was thriving and everything. She was sleepy. You could hardly see her eyes. She's always asleep. And I spoke to a few friends. I was worried. Everybody kept saying, oh, put her in the sun. Oh, she'll be fine. It clears. And I spoke to the pediatrician. She was like, oh, it will clear. So I came back and I told her, okay, I wanted to run the test again in a different facility. She wrote me a note. I went to run the test. She was like, oh, it will clear after 6 weeks. I should come back for the review. Baby will be fine. So I was home one day. I was like, no, my baby is getting too yellow. I was not comfortable. She's sleepy. I wasn't feeling well as a mother. I was very lost. So I spoke to a friend at UGMC and she was like, come in, let's see another pediatrician. So I came to UGMC. That was when I met Dr. Sharon. And she explained to me that, okay, there could be a number of factors causing this. It could be a whole lot of things. So we did some scans, some tests, and then she checked some of our previous, how do I call it, reports. And then we realized that apparently baby had a UTI from a test we ran about week 2. That went unnoticed. So that was what was causing baby's jaundice. So this was at week 5 that we were noticing what was wrong. So baby had to come in for a few weeks. We had to do the antibiotics for some days. We also ran some tests and realized that we had infection of the blood as well along the line, and we had to treat that too. And funny enough, just about 2-3 days after we were discharged, baby's eyes were white, and I was so happy. It turned out that way. I was so worried. I couldn't sleep. At a point, my breast milk it stopped coming because I was so tired, because I also had CS, and I was tired as a mother, going to sleep in the hospital, going back and forth, being worried. So my baby had to do formula for some time because I couldn't produce milk. But yes, eventually we started help at UGMC, and then she's thriving now. You should see her. She's doing very well. She's kicking. It was such a long journey, but yes, we are here now.
Thank you very much, Sylvia. So do you have any advice for parents, healthcare professionals? Other mother is also on to share the story.
Yes, I particularly wish I was told more clearly that jaundice lasting beyond a certain number of weeks or days or whatever is not normal, because my first child also had jaundice and it was the same procedure. I was never told anything else apart from, oh, do phototherapy and go home, it will be fine. So when this happened, I just assumed there was going to be same old thing. I never knew there was anything beyond that. So I just was worried. The uncertainty was killing me. So I wish there could be more education, whether or not the jaundice is prolonged, a vivid education on what jaundice entails to every mother that has to put their baby under the phototherapy. I would really like that. And for every mother, I would say don't rely on anybody else's assertion. Your instincts are always right. If you feel something is wrong, something is wrong. So take your baby as fast as you can to the hospital, because I can't begin to imagine what would have happened if I sat down and put her under the sun for more than a week or 2. Yes.
Okay, thank you very much, Sylvia. So we would like to invite our other mother. The other mother, unfortunately, because of the full capacity, we would have to hear it through the phone. So our other mother is Pamela, and she also had a child who had prolonged jaundice, and it was conjugated jaundice. So we would like to hear Pamela's story. So and unfortunately, Auntie Pamela is going to speak Tree, so we'll do the translation after. So Auntie Pamela, please, you're on the call now. You can go ahead and speak. Auntie Pamela.
Yeah.
Yes. Mpacho will call next week. You bet me a start your story. Why? Please let me know if it's not very audible. Can you hear, please?
Patrol, me the Pamela. No, so me, and me wo me bano, but me woman, no, na, me used to, now one, like, or tied that, it's another little, you, say, me used to, yes. It's no, midday, see, no, and I maybe who say, I actually to know, whether that, but, you wouldn't say, normal thing. You know, the call hospital, that was 1 week time. Into your call, no, and me go home with doctor, but me go home doctor, me catch you so. The one time me ban on the so ada yellow. Catch you so. Enye bibiana ebeko. Into the meantime, man no for intentem. And now say me wo ho a mention you so ni bi engu ne so na ebeko and I'm to you. Into your day fie no still no into your time call 6 weeks. Into your time call 6 weeks no. Na nurses no amuye we no. Omu we no. Omu ojinso ogu omu we no so. Njo nurse no so. The ban ne jinso enye into the men can show doctor na msibu. Into me kwa me catch doctor so. Say me say ya kulano. No ta catch am me say ebeko ba me nya me funso in terminate say no po na kulane normal ebeko na msibu ene de ba tu. Into your day, for me, but who say, yellow wish no, it will be necessary, and your idea echo. The corner may come. It can be say like maybe your bed general and there's no matter say. So intention na ebeko. Nam into one you say no, God then echo no, a quick. Into me call different hospital. Into me call home, and now almost sharing, but almost share no man the year lab. Into me a lab, brother, and I can't say no. The band condition are different into me. As some will say, and call different hospital. Nam to okay. Into my repair my echo, this thing, you call different hospital, no more share, no. And I'm going doing at hope to see you. If you are doing to the next day, no, my echo running some card, me love, me test to you. Into later on now, Dr. Becca me say, the bano, aye yellow na ama share enko say chan wanya you see ni liver spot dia ba liver na you say fe ya renu biliary effusia ipacha mambo ni ya na mo ja che ni see biliary effusia na me ba ni wenya it will say doctor then biliary effusia na all born and I say ni nsu da yellow no oye baby na ke for mo fa ntu light affair, but Oma finance light affair ama affect the liver no. Until the young man say, yes, only surgery. Until the surgery now, be okay. So the person down better na me think me penye mama ye surgery. Mama ye surgery ni no. Omo de start ya ba twe mo my 1 week say and 1 week na ye be do feel. Na doctor dey say surgery no mo ye no anye ejuma nti am surgery no mo ya plan no and that's what said to so issue no e wo ho nti no mbe ma ye letter si ye nkonko gastro nti no ye start gastro nti am gastro na ye kono nti am me ba ni ye funu am ye kesiye nti me bisa gastro doctor no say dey na me ba ni ye funu aye kesiye and I'll say, Diana affect me liver no, and one, and I'm a you from ISS, and the piano, the stone, as I yellow. You from ISS, over the pana 4 years on to me and say, you know, Mr. Media, a woman,
Okay. Auntie Pamela, thank you very much. Now, Mpacho Onya, how many weeks and sana ye surgery no?
Me pa, ye diyan to hospital na wo 6 weeks. Na ye je. Nti ye da ho no ma na okonya ifan say 3 months. Na ka say days to 3 months no mo ye ni surgery no.
Okay. That was in Mpacho assembly wo ho a wobɛtumi wopɛ sɛ woka kyerɛ maamefo anaa doctors fo anaa yɛ nurses fo a yɛwɔ call ne so.
Metacho, so me deɛ na metumi aka ne sɛ, mesrɛ yɛ doctors ne yɛ nurses na titi ano omu yɛ adwuma na na so omu wɔ adwuma ni mu no sɛ yɛ awofoɔ no anaa parents no yɛ nyim na anaa yɛ wo ne yɛ ba ebi wɔ hɔ no ma ɔmo da wonim hwee mpa saa de ne deɛ no sɛ wanya no ho anya ne ba nti mesrɛ sɛ yɛ wo a ɛyɛ ɔmo ani nkɔ yɛ nkɔla ne ho ɛma yɛ anaa sɛ mo ma yɛ days na time si yɛ mbra omo exam nkola no mo hwɛ nkola ne man so omo hu bibi wɔ nkola no ho a no ma tua yɛ den ahwɛ ama yɛ ntɛm na ɛbɛyɛ a ɛmɛ keetiri sɛ ne die sɛ akeetiri nti mesrɛ sɛ ɔmo ani yɛ den nkɔ yɛ nkola no ho ma yɛ because omo doctors omo wɔ hɔ no mo ɛma yɛ na yɛn nso yɛ wɔ hɔ no mo ɛma ɔmo nti mesrɛ sɛ deɛ aba no abɛyɛ nti mesrɛ pii obi saa di issue say that next time so mama ni be kon no ma tuni ahwa na tuni be ya yare no entuni de engbe tire ma tire ade wo akola ne ho mupacho entuni de.
Okay, thank you very much, Auntie Pamela. So thank you very much, everyone.
Hello.
Thank you very much, everyone. So I would like to go back to our panel discussion. So I wanted our panelists to hear this, and then we can go on with our panel discussion. So Dr. Jiman, we have heard the stories, two mothers, different causes of prolonged neonatal jaundice. I have a question for you. Apart from we as healthcare workers doing our best, if we have to engage stakeholders, what one national policy do you think would be important to implement to help reduce the incidences of prolonged jaundice, especially the ones that are missed in the system, or unconjugated jaundice that end up leading to complications or even mortality? What one national policy would you recommend?
But I think so many years ago we embarked on breastfeeding friendly facilities. I think we should channel something like kick the yellow out policy where every hospital should have to be grilled. Health workers know more, like the way we know about breastfeeding, about jaundice. And I think as a national policy through that will be a very effective way. Coining something like help kick the yellow out.
Okay, thank you very much. So, Auntie Dinah, please, I want to come to you. We know that we get deliveries these days, not just from the district health facilities, but also the CHIPS compound. So what role do you think the CHIPS compound would have to play? The traditional birth attendants, the CHIPS compound, what are their roles in preventing the complications from neonatal jaundice, particularly in identifying and preventing complications of prolonged neonatal jaundice?
To add a little to what Dr. said, as part of the national policy, I think that maybe we could have a risk assessment for mothers who are Jesus PD deficient, resource negative mothers. So when these babies are going home, that tool can be used to screen them even before they leave the facilities. I think when this is looked at, it may go a long way to help us. Now to the question about the CHIPS compounds. You see, CHIPS compounds are within the communities. They are easy to reach. They are the easiest to get in touch with these women once they deliver. But the challenge now is the referral system. So if a CHIPS compound delivers a baby or identifies a baby that has neonatal jaundice and would have to refer this baby, now where to refer the baby to is a challenge. They do not have direct contact to facilities where they can refer to. The CHIPS compounds are in hard to reach areas. So if they don't have contact of the district facilities where they can get NICU services, or even the regional facilities where they can get services for these babies, then it becomes a bit of a challenge. Their main role will be to do early identification, go into the communities or follow up on these mothers so that they can help identify early. But after the identification, what next? We should furnish them with contacts of people that they can easily reach, refer these babies to, so that the babies can get help. Then our community health nurses, we would say we go for home visits and all. But what checklists do they use to assess these babies when they go to do the home visits? Is it the normal, Madam, how is your baby doing? Is baby sucking well? There is no direct checklist that includes look out for this, look out for that when you even go ahead to do the home visits. So maybe we have that. It can help the community health nurses identify or pick up specific things that they have been assigned to go and look out for. And then the CHIPS compound also looking out for neonatal jaundice will be able to refer when they know where exactly they are referring to. They would refer on time and make sure that these mothers get to the places where the needed help can be given to them. Thank you.
Thank you very much, Auntie Dinah. Thank you very much. Dr. Anna Nibenfo, please, your hands are up.
Yes, Sharon, thank you very much. So I agree with most of Auntie Dinah's submission, but with respect to looking at a national policy, I feel we should also look into healthcare training. The more we are able to train our healthcare professionals, the more we equip them or empower them, the better it is for them to pick up most of these babies. Remember with one of our mother's story and even one baby KB who I presented, these babies report, but they are reassured. And even I think Auntie Sylvia also mentioned that she had been to several facilities. So if we are able to give the healthcare professionals at the peripheries much knowledge, then they are able to quickly pick and then investigate these babies early than to reassure and let these babies go home and then come very late when complications have already developed. So if we can actually start, and I think we can even start as a society, if we can pilot something, a form of training, it can even be on a small scale basis, just pilot it and see how best we can increase the capacity, increase the skills and knowledge of our healthcare workers. I think this will go a long way to help pick up our babies. And it's quite sad when the babies come and it's already too late for anything to be done. It's like you are against the wall and there's nothing you can really do. So I believe that once we're able to empower our healthcare workers, we should be able to pick up these babies early and on time. Thank you.
Thank you very much, Dr. Anna Nibenfo.
A quick one on that.
Okay.
I think we've discussed this before, and I think Pediatric Society, we have a very strong, we have upper hand to develop tools like Pediatric Society positioning statement on the management of neonatal jaundice, and through that, we'll be able to get more protocols to district and sub-district levels for this.
Thank you very much, Dr. Ajiman. I think all those would go a long way to help. Okay, so finally, Auntie Dora has been able to join us. So Auntie Dora, please, you're very welcome and kindly go ahead. I see your hand up. Hello, Auntie Dora. Auntie Dora, please, can you hear us? Okay, Auntie Dora seems to be having some...
Please, can you hear me?
Yes, please, we can hear you.
Okay. It's a pleasure to be here finally.
and I'm sorry that I couldn't join owing to all the network issues. But my question is this. I and a friend have over the years done some naturalistic observational survey, which may not be so scientific, but perhaps could be considered. And what we've seen is that mothers who go through a lot of stress during pregnancy, like being aspiring for higher education and during pregnancy, having a lot of stress, usually come down with babies having some of these complications. I want to know whether you have any evidence to back such or whether you have observed such. So that's my question.
Okay, so Auntie Dora, you want to find out if we have any evidence relating the stressful events during pregnancy to an increased rate of neonatal jaundice in newborns?
Yeah, in general complications of babies, including neonatal jaundice.
Okay. Dr. Jiman, can you help with that, please?
Yeah, I mean, the one possible explanation to the neonatal jaundice, we always see that mothers with turbulent perinatal period who will be so stressed out at birth with postnatal depressions definitely will not lactate well. And these babies will not be able to latch on well, will not get enough milk. And then the concept of enterohepatic circulation increases, and these babies are more at risk to get severe jaundice. So mothers should be evaluated at birth to see those going through depression and to be helped. One area that midwives play crucial role that of late we are not seeing is helping mummies latch on, making sure that they get that act very well. Breastfeeding is a practice, is a skill, and irrespective of how long you read about it, when your baby drops, it's a different thing altogether. So I think the role of the midwives in identifying and helping mothers latch on, especially before discharge, is so crucial. And I think, mothers with more depression are likely not to feed well, and probably that will be the mechanism. But for other factors, I may not be able to explain.
Okay. Thank you very much, Dr. Ajiman. So we have a few questions before we continue with our panel discussion. We have a few questions, and I'll throw it out there to any of our panelists. So the first question says, good day, my name is Makafui. First, I would like to commend the organizers and resource persons for the insightful presentation and valuable information shared on neonatal jaundice. Thank you for shedding light on such an important topic. My question is, in a CHIPS compound setting, when a newborn presents with signs of neonatal jaundice requiring urgent referral, but referral is delayed due to financial constraints, parental superstitions, or cultural beliefs, and limited availability of specialists at higher level facilities, what immediate management and monitoring measures can healthcare workers implement to reduce the risk of complications while awaiting definitive care? So, Dr. Jaman, do you want to take this?
Yes,
Or
yes,
Auntie
yes.
Fatima?
So
Okay.
I think that's what I said earlier on. So hydration is so important. Hydration is so important. And if you are the chips area and you've identified this whilst waiting, one of the crucial things is to help mom to, the baby to be feeding more frequently, because the hydration alone will help not to escalate the jaundice until you get help. So I think the concept of breastfeeding and helping these babies express the breast milk top up with the cup is so crucial.
Okay. Thank you very much. And Miss Fatima, please, is there anything you would like to add, please?
I think I would have said what Dr. Ajman said, hydration, because the liver will work on the bilirubin to convert it. It will have to have some fluid or water to help clear it out of the system. So if the water is not around, it becomes a problem. So hydration is very key.
But I want to reinforce that we are not saying that we should give the baby water to drink, but hydration in terms of IV fluids
Oh
where
yes,
you are presenting to the hospital.
hydration in terms of breast milk.
Yes,
Yes,
please. Breast
yes.
milk, and then if they are in the
IV,
hospital
rubber
setting,
C,
IV
IV,
fluids. Yes, please.
yes.
But breast
Thanks for
milk,
that.
breast milk.
Yes.
Yes, please. Thank you. There's also another question. Um, so sorry to the second woman for the impact jaundice has had on her child. Going forward, as health workers, I think we need to emphasize more on education and discharge and the signs to look out for. That we very much agree with. Auntie Dinah, please, your hands are up.
Yes, please. Adding to what Dr. and Madam Fatih have already said, I think that the fight of neonatal jaundice should not only be limited to the healthcare workers. If you're in a CHIPS compound and you're having challenges with a mother, I think the CHIPS compound staff are more close to the assemblymen, the community leaders. Sometimes when we link up to them, the patients actually listen to them more, even than what we say. So while we do the breastfeeding and hydration, we can actually link up with them to get these relatives to understand the dangers neonatal jaundice has, and maybe, just maybe, it might help convince them to come.
Yes, please. Thank you very much, Auntie Dinah. Yes, community champions have been known to always help when it comes to advocacy, particularly in the communities. So it's always key to identify them and then rely on them or use them in advocacy, and then sometimes as interventions to talk to parents of children who need some interventions. Thank you very much, Auntie Dinah. We have another question in here. Can injection vitamin K1 cause jaundice in a baby born to G6PD mothers? Dr. Anna Nebinfo, I'd like you to answer this, please. Can injection of vitamin K1 cause jaundice in babies born to mothers with G6PD deficiency?
Hello, yes. Sharon, can you hear me, please?
Yes, please.
Okay, thank you very much. I think the person who asked the question was Margaret Koraman. Thank you very much, Margaret, for the question. So the initial or the prophylactic vitamin K, which is given to babies, actually does not cause jaundice in babies. There's actually even if a baby has G6PD deficiency, it's not really a contraindication to vitamin K administration. Remember, this dose is actually very small, and the chance of it causing hemolysis due to G6PD is quite low. So you can still give the prophylactic vitamin K dose to all these babies as well. Thank you very much.
Thank you too.
Yeah, still it should be given. The benefits against, bleeding far outweighs anything. So it should be given.
Okay. Thank you very much, Dr. Ajiman. So please, we have a question from the YouTube page. I think this is from a mother or from a parent. Please, I have a 2-week, 5-day-old baby who was jaundiced on day 4 and started phototherapy. We came for review and clinically the baby is not jaundiced, but lab results still showed high bilirubin levels 213. Okay, so mommy, is it possible to, if it is possible, kindly come to any of the tertiary facilities and register to see a pediatrician, and we'll be able to help you from there. 2 weeks, 5 days old baby, that baby will need assessment. So kindly send the baby to the hospital and let's register to see you from there. Please, we have another question from Alberta Amwa. Please, can phototherapy be done for babies with jaundice after 14 days while preparing for a referral? Dr. Jiman, can phototherapy be done for babies with jaundice after 14 days of age while preparing for
So
referral?
again, these things it's not yes or no, right? Everything is individualized. You have to assess this baby well. A 14-day-old baby, as we've already discussed, should definitely might have had a liver function test done. And based on that, we'll take it from there. If liver enzymes are raised, the conjugated part is raised, you have to expedite referral and not to waste time on phototherapy. So the answer to this is you cannot say yes and no. It's individualized.
Okay. Thank you very much. Please, we have some hands up. So please, Margaret, I'll ask you to unmute briefly. We'll be coming We are gradually inching towards the end of our discussion, and I'll ask our panelists one last question before we go. But Margaret, please kindly ask your question. Hello, Margaret.
Hello?
Yes, hello.
Yeah, hello. Please, can you hear me?
Yes, please.
Okay, I couldn't join early, but I heard some Jaundice. Please, can you give me brief explanation? Thank you.
Margaret, please, can you kindly repeat the question?
Okay, please, I said I heard unconjugated jaundice. Can you give me brief explanation?
Okay, so Dr. Anna Nebenfo, please, Margaret would like to know what the meaning of unconjugated jaundice is, please.
Okay, thank you very much, Sharon. So, Margaret, when you have a baby with prolonged jaundice, this is a baby who, if it's a term baby, jaundice persisting after 14 days, and then for preterm babies after 21 days. But in prolonged jaundice, you need to categorize whether it is conjugated or unconjugated. So the first thing you have to do is to do a liver function test. Then you fractionate the percentage of the direct bilirubin. So it is direct bilirubin over the total bilirubin, and then you express it as a percentage. So if you do this percentage and it's less than 20%, this is what we call unconjugated hyperbilirubinemia, meaning the unconjugated. Remember that when you are going through the breakdown of red blood cells, before the bilirubin gets to the liver, it's broken down to unconjugated hyperbilirubinemia. So it means you have high levels of the unconjugated hyperbilirubinemia. But when you do it and it's more than 20%, then this is called conjugated hyperbilirubinemia or neonatal cholestasis. So this one gives you a clue as to where the problem is starting from, and then you have some ideas when it comes to the differential diagnosis. But I think I will share my slides so that everyone can have access to it, and then you can read more on it. Thank you very much.
Thank you very much.
You're welcome.
Thank you very much, Dr. Anna Nebenfo. Please, we'll give Auntie Dora. I see your hands up again. So please, Auntie Dora, I would like to ask, you have many years of experience in preventive health services. Please, is there anything you would want to add to our discussion in terms of early recognition, and where are our lapses, and how do we improve on that, please? Mrs. Jones, do Auntie Dora? Okay, I think she's gone off the call again. Okay, so I think Auntie Dora, we've lost Auntie Dora on the call. I would want to briefly check. Okay, so our chat boxes. We have one question from Abna Sewa. Please, my question is this. I went with my daughter to a standard hospital at La Paz to deliver. Unfortunately, I observed that the baby was not given breast milk until after seven hours. The pediatrician had already seen the baby before then. I was very shocked because I thought the baby would get jaundice. Later, they put the baby under phototherapy. My question is, why did they wait 7 hours? So Abna Sewa, I'm not too sure, I'm not too clear of the question. Is it that why did we wait? Why did the health? Why did they wait 7 hours for the baby to be put to breast? And we'll need more clarity on that, so you can expand that in the chat box. And then we have a question from Prisla Kuchaneji. Please, what is the standard protocol for management of jaundice? What is the standard protocol for management of jaundice? Dr. Anna Nebenfo.
So unfortunately, we do not have clear-cut guidelines or standard protocols when it comes to managing prolonged jaundice in Ghana. I think I was able to give a few, the algorithm that I shared, which shows you what you are supposed to do, how to investigate, and then how to manage and refer the child if there need be. I believe we can further develop this initial algorithm and then share it with other healthcare workers across the country, and then probably get much firmer or much well-developed guidelines so that anybody who comes across a baby with prolonged jaundice, you have something that is easy for you to refer and you know what to do at every point in time or at every step. So we don't have anything yet, but I believe that by the end of the year, we should have been able to put something more practical out for everyone to be able to use. Thank you very much.
Thank you very much. Dr. Jiman, please, I have a question from Isa Said Umar, who says, can exchange transfusion help a baby who has suffered the complications of severe form of jaundice? A baby who has already suffered the complications of severe form of jaundice, can exchange transfusion?
Am I audible?
Yes, please, you are
Yes.
audible.
So again, there's no clear-cut answer, yes or no. It depends on the baby in question. If last week we had a baby who had suffered severe complications and cardiorespiratory baby was not stable, this is a baby who can't stand the vigorous procedure of exchange transfusion. So discuss with parents and not do exchange transfusion. If you get a baby who is very early showing signs but cardiorespiratory stable, why not go for it? Because doing exchange transfusion will further prevent further damages. If this baby is to have cerebral palsy, maybe if you did not do the exchange, baby will go on to have a hearing loss, will go on to have learning difficulties. So everything depends on the baby in question, and every baby should be individually, it should be assessed individually and then based on the clinical findings and shared decision making with parents, decision taking. So there's no clear-cut answer, yes or no, to this. It depends on the baby in question.
Okay. And then Dr. Jiman, please, another question from Alberta Amwa. Please, for preterm babies, is their diagnosis done after their corrected gestational age?
No, it's 21 days after delivery.
21 days after delivery. So I hope we've been able to answer all your questions. For those who have more questions, you can put them in the chat box. The panelists will engage you over there. Thank you so much to our panelists. I would like to ask one last question. So to all our panelists, I'll come to you one by one. So imagine this. Next year, same time, we have a presentation like this, and we have statistics to back it. And Ghana has successfully reduced the cases of severe neonatal jaundice and prolonged neonatal jaundice by 50%. And this is an imagination. What specific change must happen between now and then for this to become a reality? What do we need to do between now and then? So this is just in a 1-year period for us to be able to successfully reduce our cases of severe neonatal jaundice from where it is and cut it down by 50%. What specific changes should we or what policies should we implement? What changes must happen now for us to be able to get to that point? Dr. Jaman, please, you can start off, and then Auntie Diana, Fatima.
I don't want to wake up from this dream.
It will be a very good dream, truthfully.
Yeah. So I think, as we said, we need to empower the healthcare workers working with children. Everything starts probably from antenatal, where be doing normal booking bloods of pregnant women. We do this to do risk stratification, right? To pick up mothers who are O negative, especially in Ghana. One of the horrible things we see is the combination of mother being O and baby being B. So all blood group O mothers and results. Occasionally we see results. We hardly see results, but the day we see is a fatal one. So midwives are taught that when mother is O, we need to look carefully for these babies. These are babies that probably the protocol should say that these are baby that we should check the bilirubin even before discharge. And then based on that, we do risk stratification in terms of when to come for review. And then postnatally, we need to be aggressive with feeding. All midwives should be equipped with breastfeeding skills to be able to help mothers establish breastfeeding before discharge. And then making sure that maybe Pediatric Society develop a national protocol on the management of neonatal jaundice, that a doctor sitting at a district level at one place and another will do the same thing. A midwife, especially on postnatal visits should do the same thing. Weigh baby, make sure that babies who've lost so much weight, you are escalating to the doctor for review. And then most importantly, have laboratory facilities to do the turnaround time bilirubin. If it's not even available, we should have the transcutaneous bilirubinometers. I'm speaking mainly for probably district, regional, and tertiary centers.
Okay. Thank you very much, Dr. Jiman. Thank you very much. Fatima, so let's assume that this dream is actually true. Next year by this time, 50% reduction in our neonatal jaundice rates. Please, what do we need to do between now and then? Dr. Jiman has said a lot, but what do we need to do between now and then?
I think we are now discharging mothers very early with their babies, especially mothers who deliver via SBD. By 6 hours, baby and mother are gone home. So I think we could work on early reviews and early discharge testing. So before baby is discharged home, we should test the baby's blood group, GSSPD defects, and all those things to know how we can categorize such a baby. And once such a baby goes home too, we should expect the baby to come back for review in about 24 to 48 hours. We shouldn't wait for about a week, the normal week that everyone comes for review. I think it will really go a long way to help us.
Okay. Thank you very much, Fatima. Auntie Dinah.
Yes, please. I think that besides the initial baby examination post-delivery, be it spontaneous vaginal delivery, be it a cesarean section, elective or emergency, I think that on daily basis, these babies should be examined, because the routine is that once baby is born and we do the first baby examination, the next time the baby is examined is when the baby is going home. And so if it's a cesarean section baby that is staying with us for, let's say, 3 to 4 days, doctors come and we are reviewing the mother. The concern is with the mother. Midwives are checking vitals for the mother. We are just checking vitals and we are moving along. But if on daily basis, we make a conscious effort to look at these babies, to pick up even minor discolorations, I believe that it will go a long way to help us identify early and then start early treatment so that we don't get to instances where we'll have difficult or complicated jaundice to manage. Thank you.
Thank you very much, Auntie Dinah. And Auntie Dora. Is Auntie Dora still with us, please? Auntie Dora.
Hello, I can hear you. Can you hear me?
Yes, please, I can hear you.
Yeah, because I wasn't hearing, I was jotting down some of the preventive measures. But with regards to the question you asked, I was saying that we are talking about halving the incidence of neonatal jaundice, right?
Yes, please.
And I am thinking that the free primary health care initiative that has been introduced is promising, because one of the factors that make people don't seek care early is because of finance. So we are hoping that that will also help. I don't really see later discharge for SBD mothers from the hospitals as feasible, because sometimes we even have shortage of beds and the rest. However, in the past, we used to have a team that will follow up this woman at least for 1 week. The team comprised the midwife, the community health nurse, where we go and assess the woman and the baby. But in the absence of that, because these days the community health nurses have so much on their hands, in the absence of that, I endorse the 3 days after discharge coming back to get postnatal care. But we all have to be vigilant. Antenatally, we have to put in measures to prevent neonatal jaundice. For example, if we have done the assessment and we realize that this woman has some infections, let's treat fast, because some of the infections can cause premature birth, and that also predisposes the child. Yeah, in delivery, we should also observe the timely clamping of cord and what have you. And then postnatally, let's assess all our babies very well and follow them up. I think there's a little I want to add.
Okay, thank you very much, Auntie Dora. Thank you so much. We have gradually gotten to the end of our panel discussion, but then there were two questions that came up, and I thought it was important to address. So please, someone wants to know, is sunbathing still recommended? And the answer is no. But I'm sure our neonatologists will want to throw more light on that. Is sunbathing still recommended?
But you've answered the question. It's still no.
Yes,
Right,
please.
because I think if you put all colors together, you get white. So definitely it's the blue-green spectrum we utilize in neonatal jaundice, and it's in the sunlight. But unfortunately, there are other harmful UVs and infrared in there that may harm the baby. You cannot control the temperatures of the baby too. So in this day and age, and we think we want every baby to come to hospital. And hospitals should be very friendly so that we don't kick these parents away.
Okay. And then Dr. Juman, just one more. How many hours can a baby stay in the under the phototherapy machine? Someone wants to know.
It depends.
Firefly, which of them, whichever one
No,
of them.
so it depends on the clinical condition of the baby. Normally, when you put the baby under the phototherapy, it may take about 4 hours for it to kick in. So and depends on how the phototherapy will reduce the rate. So no two babies are same. So we cannot have a definite answer. It depends on how the phototherapy will reduce the jaundice for a particular baby.
Yes, please. Thank you very, very much. Dr. Anani Benfo, please, any final words?
I had my eyes closed picturing your ambitious goal of 50% reduction till you called me. I believe that we should walk the talk. We've said a lot today, but I think we should look at the low-hanging fruits that we can make some change now, so that in the next year, when we meet again to discuss newborn jaundice, we can share more success stories and then know how far we have come from where we are now. I think we've said a lot today, but let's identify some of the ones that we can implement almost immediately in our facilities on a national scale, just to help put a change out there. Thank you very much.
Thank you so much. Thank you all so much for joining us and agreeing to be panelists. We have learned a lot. I particularly have written very boldly early recognition with so many exclamation marks, parent education, better referral systems, as well as healthcare, health worker retraining, and then access to timely treatment. So thank you so much to our panelists. We are very grateful. So we want to move on quickly to the next program. I'd like to call on the PSG Greater Accra chairperson, Dr. Ernestina Shandorf. So usually every year we try to award the hospitals um, that have shown we undergo advocacy programs in May, and we try to award the hospital that came up with the most innovative and the most innovative ways in jaundice advocacy during the month of May. So I'd want to invite Dr. Shandorf to do us the honors of announcing whichever hospital won for this particular year. Dr. Shandorf. Okay, so Dr. Shandorf is currently unavailable. So we'll quickly go to our drug presentation from Indus. And then after that, we'll announce the winners for the year, please. Thank you very much. Indus, Desmond, please, are you on the call?
Yes, please, I'm here.
Okay, thank you very much.
You're welcome.
Over to you.
Okay. All right. Good evening, everybody. My name is Desmond from Indus Life Sciences, and I would like to quickly remind you some of our wonderful products on the market that are available in various hospitals and health facilities that you work. And we are saying that Indus produces quality medications for good health. In fact, we have our number one brand, which is called Zincovet. And as we all are aware, Zincovet offers optimal quality of zinc enriched with other vitamins and minerals. So to build immunity and also to treat diseases effectively, we have Zincovet in a tablet, in syrup, and also in a drop form. In fact, the syrup is reserved for children, and sometimes some doctors will complain that when they gave Zincovet syrup to a patient, it increased their appetite. Yes, because of the lysine in Zincovet, it's able to help boost appetite to some extent. And the tablet is reserved for adults only. So we are saying that in immunity, Zincovet should be the number one medication. And also in sickle cell management, as we are all aware, Zincovet is able to help strengthen or decrease the pain crisis and also help reduce hemolytic processes. Yes. So Zincovet restores nutritional levels, thereby preventing the severity of SCD. Again, we also have got the untold story of zinc in the treatment of anemia. We did a research and we saw that when a person is deficient of zinc, it may lead to anemia, and this is why. Zinc acts as a catalyst for iron metabolism. Zinc is also essential for erythropoiesis. Zinc plays a vital role in hemoglobin formation, and zinc is important for maintenance of erythrocyte integrity. So we are presenting to you our Zincovet, which is a trusted hematinic with zinc advantage. So this is the liquid, and when you give 5 ml TDS, the patient will get 50 milligrams of elemental iron. So for a predictable rise in HB, we have Zincofa liquid always available. And when you give Zincofa liquid to any child holistically for 30 days, they may get 4 grams per deciliter rise in hemoglobin. We are also saying that irrespective of origin, being acute wound, exudative wound, burns, slow healing wound, surgical wound, chronic wound has to heal. And both acute and chronic wound are susceptible to contamination and colonization by a wide variety of aerobic and anaerobic microorganisms. And we present to you with the trendsetter in wound management, that is DRESS. We have the DRESS powder, we have the ointment. It comes in 10 grams and 30 grams. We have the solution, which also comes in 30 mils and 100 mils. In fact, the DRESS powder is for exudative wounds. The ointment is for non-exudative wounds, and the solution is for pre- and post-surgical procedures or fresh wound irrigation. We are saying that DRESS is a trendsetter in wound care. We also have got our Viscoff S, which contains ambroxol, guaifenesin, and salbutamol for productive cough due to asthma, acute and chronic bronchitis, bronchial spasm, and COPD. And in fact, it's the only cough preparation with a surfactant action in Ghana. Please, we should note that for Viscoff S, it starts from 6 years and above. We also have got our Viscoff plain, which contains ambroxol and guaifenesin for wet coughs. It also starts from 5 years and above. This is our Viscoff D, which has dextromethorphan, cetirizine, phenylephrine, and race menthol for dry cough associated with sneezing, runny nose, nasal congestion. In fact, when you take VSCOV-D, you'll be guaranteed of relief in less than 30 minutes. It also starts from 6 years and above, please. I'm here to also talk to you about the 7 reasons why Nugel stands out among other antacids. And this is a package of the Nugel, which is a third generation arginate antacid. So these are the 7 reasons. In fact, when you give Nugel to a patient, there will be instant action in less than 5 minutes. And also, it has optimal acid neutralization capacity, and it's a third generation antacid with the arginate raft advantage, and is able to last up to 4 hours. And it's a balanced antacid, which means that it may not cause constipation or diarrhea, and it is very, very safe. We also have got our wonderful products that we've seen around in facilities. And we are saying that superheroes of tomorrow's Ghana need super nutrition. And we are reminding you of our Cherry Pep, which is the first of its kind formula of nutrient-dense chlorella, which has got chlorella growth factor, zinc, lysine, taurine, and multivitamin. As we all know, chlorella is a fresh edible water algae which has got exceptional nutritional profile. It is rich in protein, amino acids, fiber, fats, carbohydrates, chlorophyll, vitamins, and minerals. Cherry pep has got the benefit of cognitive development. It is coming from the chlorella, which has got omega-3 and omega-6, and are very critical for brain health and cognitive functions. So in the cases of children with CP, when you put them on cherry pep, they will do well. And also their gut health. Chlorella possesses a probiotic effect, thereby preventing some of these unnecessary diarrheas that they may present to you with. Chlorella again is able to stimulate the production of growth hormone, which is a key regulator of height gain during the growth phases. Our cherry pep also has got lysine in it, which helps with the absorption of nutrients like zinc, iron, and calcium. Lysine may also stimulate appetite. So in case cherry pep is being given to any child and the mother comes back and complains that my child is eating too much, please, we should know that it is coming from the lysine, which is boosting up the appetite. It also aids in detoxification. That is a work of chlorella. So it binds to some of these heavy metals that are found in food and also in the system of children to prevent their reabsorption. So for immunity, for growth, for cognition, and detox and gut health, I think we should all put the children that we see on cherry pep instead of any other multivitamin. It starts from 2 to 6 years, they take 2.5 to 5 meals, and 7 to 12 years, they take 5 to 10 meals. And we are saying that cherry pep is a super nutrition for every child. It's taken once a day or as directed by a healthcare professional. Thank you very much for your time. Please, any questions?
Thank you very much, Desmond. So I don't see any questions in the chat box, but you can engage once questions start coming in the chat box. You can engage and answer. Thank you so much, Indus. Thank you, Desmond.
Thank you.
So up next, I think our PSG Greater Accra chair has joined us now, Dr. Shandov. So Dr. Shandov, please, over to you. What we've been waiting for. You've been teasing us in the chat box.
Yeah. So thank you so much, Dr. Sharon. So it's been an amazing month of May, and I believe a lot of people have done a lot of work. And this webinar that we've had has been very instrumental to opening our minds that we are all part of the solution. We've heard the stories from the mothers, the good and the bad, and we can make a difference to make sure that no child suffers the consequences of late detected jaundice or poorly treated jaundice. So as we go home, please remember, we are all part of the solution. First of all, I'd like to say thank you to every facility that participated in the advocacy, whether it's through your routine work, whether it's through advocacy to the mothers, to the clinicians, to the nurses, to the general public about neonatal jaundice. We really appreciate the work you do, and it goes a long way to save a baby. So don't take it for granted. These awards are important to make us a little bit more competitive, but go knowing that we are all winners in this month of May. So I've seen in the chats, lots of people have put their guesses on the winner of this year's Neonatal Newborn Jaundice Awareness Month. And I must burst your bubble, but none of them are, a lot of them were close. Some of them were actually in second and third place. But the winner of NJAM this year has shown a lot of community engagement, a lot of staff engagement with very impressive attendance. They also had nice skits, humorous skits to help people understand what jaundice is. And they used the various local dialects to make sure that everybody understood what newborn jaundice is and how to spot it early and treat it right. So the winner of this year's Newborn Jaundice Awareness Month is Shai Osudoku District Hospital. So congratulations to the winners. And we are going to see you very soon with your award. You have bragging rights for the next 12 months until the next May, where we start all over again. But this doesn't end the advocacy for newborn jaundice, because newborn jaundice tends to be the highest cause of morbidity and mortality in our little ones. And we know how precious our babies are. A mother has carried her baby for 9 months, and it's a joy of everyone to see a baby born. So let's make sure that no child has the complications of newborn jaundice. Let's try and prevent it so that next year by this time, we will exceed the 50% reduction, God willing. So thank you all so much, and congratulations again, Shai Osudoku District Hospital. So Dr. Sharon, over to you.
Please, Dr. Shandov, are we allowed to tell them what they get so that the other
Yes, please, you can. You can tell them what they get.
Please go ahead and tell them so that they can start preparing. Maybe they'll start making plans towards next year, advocacy plans.
So this year, fortunately, we have a special plaque made for the winners of this year's NJAM. They'll also be privileged to have a visit from the executives, where we'll sit down, see their challenges, and see how we can also contribute to make things better in their facility. This year, we had a joint partnership with Onya Foundation and AHS, Africa Health Solutions, where we are trying to distribute as many phototherapy units to the various facilities that need them. So that will still be ongoing. So please, next year, if your facility does extremely well, you may have a photo unit. So please, let's make sure we are all in the fight against newborn jaundice. We are all part of it. So for now, the phototherapy unit for Greater Accra region went to the Pantan Hospital, because they were really overwhelmed with patients and didn't have a single phototherapy machine. So we have donated that machine to them. Next year, God willing, we would have more phototherapy machines. So that's also an opportunity for more facilities to have this life-saving equipment. But Shai Osudoku, expect us to visit you very, very soon, and expect us to bring you your trophy for the year. Thank you.
Thank you very much. Next year we must take it. We won't allow anyone to take it from us. We are already putting down points to prepare for our advocacy for newborn jaundice. But then all these need to translate into action as well. So next, I would like to welcome Dr. Medruth Sam. She will give us a few announcements, general announcements, and then we'll go ahead with the closing remarks and then closing prayer. Dr. Medruth Sam.
Hello, good evening. Thank you very much for today's wonderful attendance. It's been a very, very exciting meeting. So we have a few announcements just to remind members about payment of dues, also regularization of membership of with the Pediatric Society. Today we've had a lot of our nurses join and midwives joining us. So we want to extend an invitation to you to make your membership more official. Also, we continue to raise awareness about our project SOS, which is still in the works. We'll be having an in-person meeting in the nearest future. We'll communicate further details as well. We also want to remind members that we'll be having our next monthly meeting, which also promises to be exciting on financial nuggets. So stay tuned for that. So that will be all for now. Thank you.
Thank you very much, Dr. Medruth Sam. Dr. Shandoff, please, over to you, closing remarks.
Okay, so thank you all so much for your attendance. Thank you for your participation. Thank you for your involvement in today's meeting. And as I've said earlier, this is just the beginning. We need to make sure neonatal jaundice or newborn jaundice does not cause debilitating consequences for our children, and that we will reduce the complications by half, hopefully by next year. There's a question that I'd like to address. So Noble asked if the phototherapy units were just for Greater Accra. So to clarify, no, it's not for just Greater Accra, it's for the whole of Ghana. This year we had 3 phototherapy units. So one is in the coastal area, that's Greater Accra region, one is going to the central area of Ghana, and one is going to the northern region of Ghana. Hopefully, with this partnership, we'll be able to advocate for more phototherapy units so that we can distribute more phototherapy equipments to various facilities. So no, it's not just for Greater Accra, but it's for the whole Ghana. So back to my appreciation. I thank you all, especially our panelists and our dear presenter who dissected the other causes of jaundice very well. I hope you all remember her formula of jaundice baby, pale stool, dark urine equals to biliary atresia until proven otherwise. I hope you remember that. And thank you to all our panelists, our nurses, Dr. Ajimai, our mothers. We are very, very grateful for sharing your story and helping us realize what the things we can do better to make sure no baby suffers. So thank you to all the participants who stayed all the way to the end. We hope you learned a lot, and we hope that you would tell someone to tell someone so that everyone would know that newborn jaundice is preventable and treatable, and spotting it early makes a big difference. So thank you all very much for your participation. And I hand over to our moderator, Dr. Sharon Ogbabiche.
Thank you very much, Dr. Shandoff. Thank you all for joining in today's webinar. As we conclude today, let us remember that behind every case of prolonged jaundice is a child whose future may depend on how quickly we act. So let us leave here committed to spotting it early, treating it right, and giving every newborn the best possible start in life. Thank you and good evening. We would like to welcome Dr. Med Papa for our closing prayer. Dr. Med Papa is here for closing prayer.
Hello, thank you, Sharon. Shall
Papa,
we?
please a minute. Please, before we leave, please make sure you have filled the CPD forms. Those on YouTube is being shared in the chat box. I think it's been shared here as well. Please make sure that we have all filled the forms for our CPD. Thank you very much, Papa.
Shall we pray? Our Father and our Lord, we thank you for today. We thank you for this gathering for Pediatric Society, the Greater Accra chapter. We thank you for our resource persons and everything that they've taught us. We pray, oh Lord, that everything we learned today will be used in the benefit of our newborns so that we find a reduction in our cases. We pray, oh Lord, that as we go to bed, as we rest, you be with us, help us, you guide us. So that in the end, all the glory will be to your name. This is what we ask through your Son, Jesus Christ, our Lord. Amen.
Amen. Thank you all so much and have a wonderful weekend. And please remember, spot it early, treat it right. Before we go, I'm so sorry. I wanted us to take a group picture. So those on the Zoom call, if you can just briefly put on your videos so that we can take a picture, a group picture. So please put on your videos. So please, do we all have our videos on? I'll take a number of pictures. And we want a smile, a big smile. Okay. So I have some beautiful pictures. Thank you all so much and have a blessed evening. Thank you.
Thank you very much to our dear moderator.